Good afternoon, everyone, and welcome to the HFMA Colorado Chapter webinar series. We want to take a moment first to recognize our annual business partners who not only provide financial support for our chapter, but they also share their knowledge and all of their resources through webinars like these. We hope that in order to support them, you'll look at them first when you have a need arise for any services. A reminder, certification is included in your membership now. So if you've been considering getting certified or interested in getting certified, reach out to the chapter. We'd love to help you on your journey. Today's webinar is Leverage Virtual Health Solutions to Deliver Improved Patient Outcomes. It's my pleasure to introduce you to our speaker, Amy Newson. Amy is the Senior Director of Revenue Cycle at Civista RCM. Amy Newson is I repeated myself, I apologize. Amy has an in-depth knowledge of eligibility requirements at both state and federal levels, and extensive experience in providing access to care to healthcare providers' most vulnerable community members. She has the insight needed to understand and navigate the complexities of eligibility services as its delivery changes in the healthcare industry. Please join me in welcoming Amy.
Thank you. I appreciate you allowing me to speak today. All right, I'm going to go ahead and share my screen. Okay. Make sure. Can you guys see the blue speaker? I just want to make sure. I don't have it. Okay. Awesome. Okay, so we're going to go ahead and get started, and we're going to discuss leveraging virtual health solutions to deliver improved patient outcomes. So for the agenda today, we're talking about market trends. We'll be talking about patient consumerism, patient segmentation, and a patient balance management program, all with services and solutions that can be done virtually and still create the same engagement. So with the major trends in the market today, we're seeing this complex regulatory landscape with an increase in enrollees placed in value-based care models, which are typically your managed Medicaid, your Medicare ACO plans. Healthcare providers are facing reimbursement pressures driven by a shift from traditional fee-for-service to value-based models. There's an at-risk revenue and the complexities associated with new reimbursement models. They're with challenging operating systems, and they've always had thin margin profiles. And then there's also administrative costs that are expected to increase by 100 to 300% in the next several years. With patient responsibility, we're seeing this continued rise in the patient being the payer. In fact, in a recent study, the patient responsibility is the third largest payer currently. A couple of stats with patient responsibility, $156 billion expected increase for out-of-pocket payments ranging from the year 2015 up to 2023. Enrollment in high deductible health plans has nearly quadrupled since 2009. And patient medical liability for self-pay patients, those without insurance who pay services out of pocket, are growing 20% each year. The rate of bad debt for insured patients is increasing to 30% each year, with consumers now paying more in healthcare costs than employers. So it's shifting the burden on consumers and the payment role for providers. Providers are focused on being able to collect directly from patients, creating increased attention on solutions that would increase patient engagement, and being able to obtain collection. So calculation of correct patient responsibility, through eligibility verification and estimation programs. It elicits the need for efficient solutions. When we are creating a patient experience, and the patient is responsible, we need to think about how the patient feels through this and how we tailor to their needs. So with increased patient responsibility and the cost hitting their pocket, more patients are doing research on the cost of services and how the service is delivered. And there's a need for new functions on upfront collections. That's not only great for financial viability, but it's also great for the experience for the patient. And then we have the rise in cost utilization. So in the market today, we hear a lot about needing to do more with less. And how do you increase the ability to collect and create the experience, but with less resources, less technology, with less resources and technology and spending overall less. So I'd like to take a poll. So the question here is, do you use telehealth in your functional area? We'll give that a few seconds here. Awesome. So 25% yes, 63% my organization offers telehealth services, but we currently do not use them in our area. And 13% my organization does not offer telehealth services. So I'm going to talk a little bit about telehealth. This, with telehealth trends in healthcare, so this is related to Medicare beneficiaries. So in 2020, there's an estimated 55 million Medicare beneficiaries, and more than 1 in 4 Medicare beneficiaries had a telehealth visit between the summer and fall of 2020. 27% providers had offered telehealth, and the beneficiary had a telehealth visit, whereas 33% the providers offered telehealth and the beneficiary did not have the telehealth visit, and 40% was either not offered or left unknown. So I want to take an opportunity to really talk through and highlight telehealth and supporting this market trend. So while telehealth promised benefits such as ease and convenience of patient care, prior to COVID-19, it really was not scalable across health systems. This was largely due to the restrictive state and federal regulations, as well as an inconsistent practice by commercial payers, which limited telehealth reimbursement to select patient populations in rural areas. The mainstream adoption of telehealth was further compounded by the challenges of integrating virtual care technology with the electronic health record. So, however, recognizing the need for continued patient care amid social distancing guidelines to slow the spread of COVID, in March of 2020, the government introduced waivers under the Social Security Act to vastly expand telehealth services. CMS had subsequently relaxed COVID-19 telehealth reimbursement guidelines. They removed geographic restrictions. They relaxed the technological restrictions for both providers and patients, and reimbursed video visits for both new and return patients at the same rate as in-person visits for over 80 services. As commercial payers followed suit, this had propelled the rapid adoption of telehealth. Providers nationwide had switched 1/3 or more of their in-person care to telephone and video encounters with the onset of the pandemic. But now we're starting to see that the volumes of telehealth visits have declined in the recent months. It is clear that telehealth is here to stay, but there's a lot of opportunity for telehealth. And over 80% of respondents had indicated that telehealth had improved the timeliness of care for patients. And similar percentages said that their patients have reacted favorably to telehealth for care. So I want to talk about a poll that was done. So a poll that was conducted specifically for hospital systems, where the question was, what is your greatest revenue cycle management need? And the top two that I'm going to talk through today was value-based reimbursement and alternate payment models, and patient liability and consumerism. This is something to think about with the realm of value-based models, different payment models, cost efficiency, and automation. In addition to this poll survey, on the right-hand side here, a survey was conducted with patients regarding consumerism, and 79% of patients consider billing and payment experience when they're choosing a healthcare provider, and 51% of patients are concerned about affording their bill and having coverage. So I want to talk about the value-based care and alternative payment models. Value-based care is a healthcare delivery model in which providers, including hospitals and physicians, are paid based on the patient health outcomes, and it differs from a fee-for-service model in which providers are paid on the amount of healthcare services they deliver. So these type of models, they allow for providers to focus on the patient's care and not have to worry about cash flow. And ultimately, they're doing the right thing for the patient, which is patient care. So this model is prospectively determined revenue stream. It's an evolution of risk sharing, and it produces value and high quality health. And the model also focuses more on the patient outcome and the beneficiary experience. So it reduces overall program expenditures and it improves the quality of care. Providers could be enrolled in one of these value-based care models with managed Medicaid, or they could be partnered with one of the approved DCE providers with CMS. Part of incentives and benefits behind these models with these payers is to support patients by ensuring that, if applicable, the patient has access to government community benefits, which can aid and support their care. So it's looking at social determinants of health, being able to assist patients with food stamps, transportation, pharmacy assistance. The goal is, and secondary insurance or Medicaid insurance. The goal overall is to be able to reduce the number of times that patient has an unplanned visit in the ER or an inpatient admission. Many patients do need community benefits that will help aid and promote preventative health problems. And it can result in the patient being seen in the hospital. So an example of a social determinant of health is you have a diabetic patient who needs to see a dietitian or a nutritionist, and they need to regulate their diet, and they need access to healthier foods, but they really need help with secondary benefits to pay their large out-of-pockets expenses, and they need access to food stamps so they could buy the right foods and they have the funding to do so. So by supporting that patient proactively in the community through a virtual way, through engaging with them and obtaining food stamps and Medicaid coverage really helps with incentives in that value-based model that they may be in. So I want to talk a little bit about the second START item with consumerism and the patient experience and the impact on providers. So our patients are becoming consumers, and the burden of healthcare costs is shifting from the payers to the patients. So with the new trend, patients are doing more research about the cost of services. If a patient's responsible for that liability, they're doing more research on how much that service actually costs. And we're seeing some competitive options in the market today that has a lot of patient-enabled healthcare services. Patients are using their own technology. They're joining telehealth visits now. They're even buying their own medical kits that you can buy at CVS or Walgreens or Amazon. And these options are becoming big disruptors in the market. Patients are taking ownership of their healthcare, and they're becoming savvy in the way they look at healthcare. So providers are also measured on patient experience. And surveys are not typically done until after discharge when the patient receives the awesome clinical care. They may forget that once they get their bill. And patient experience is really key now, and providers are measured on that patient experience. So with HCAHPS scores, they're focused on the patient's overall experience, and it's determined that providers with higher scores have better financial outcomes. In fact, 46 to 56% of patients are dissatisfied with the amount of cost information available prior to service. So as we're focusing on patient consumerism, that's not, typically common in healthcare as a term. We want to really think about how we ensure the best patient care from a clinical perspective, but now how do you incorporate that consumerism like other industries do to create the happy customer? So when we talk about, we're finding that there's a symbiotic relationship between patient liability and service level expectations. As we see patient responsibility rise, the cost burden is shifting to the patient. We're seeing that there's also an increase in service level expectations. So patients know they're responsible for paying for their care. They also want to have a better experience for their money. They want better quality of actual administrative services for their money. So high level of patient responsibility equates to a high level of service expectation. The more we expect patients to pay us, the better we need to be in actually providing some of these administrative services on patients. So as we move towards the overall concept that the patient is the payer in the revenue cycle, it's important to think about services related to connecting to the patient and how to make the patient's life easier. So offering great value, increasing the experience, improving cash collections, and improving productivity. So if we look here at this chart and the patient's in the center, and we look at the ability, their ability to pay as the key components to enhancing their experience, there are a couple of things that we need to think of here. So one is the access and coverage determination. So helping patients understand their coverage and how it's applied to their account. The second one is the estimation of liability and propensity to pay. So helping that patient to understand, as well as the staff communicating with the patient, what their liability is. What really helps here is education that is not only provided up front by the front end staff, but to anyone that's working with that patient. So hospitals, health systems, physician offices, they're all aligned on set topics that are discussed with the patient in terms of their liability. A lot of times patients will defer their care because liability issues. So this is really important for everyone to be involved and understand that approach regarding liability. Enrollment qualification. So identifying patients who are presenting as uninsured or underinsured and having that ability and knowledge on what programs are applicable for them to help them with their cost. And then point of service account resolution. So this is a barrier to health systems, especially with small community areas where the registrars may also see patients at the store. They may see them at their local gathering. It can make it uncomfortable when you're asking for money, right? And you're seeing these patients frequently. It's important that patients are well informed and they're connected to the right area to help them with their liability. So this is important to have conversations in the beginning of the process rather than waiting till the end when they're getting that bill. And then the post-service account resolution. So this can be for services that are unable to obtain an estimate at times where like the patient may come in and a different procedure may have been chosen by the physician. So just being able to interact with systems and patient segmentation, it can help that patient through these types of situations. And then patients can have the ability to pay over the phone, through portals, online. So I want to talk through the, utilizing patient segmentation to reduce cost. So the overall value here in reducing by investing in advanced segmentation, this can be done remote or virtually in a lot of these service functional areas. And you can reduce employee turnover by ensuring you have the right HR education solutions and you hire the right caliber of people that can engage with patients and will educate those patients. They need to be able to provide that quality and establishing the relationship with the patient. So, we're kind of finding it's no longer like a check off and go. They really need to work and creating engagement with that patient to help with that experience. The patient access team really is the gateway to revenue cycle. And generally there can be a lot of high turnover in this area. So having colleagues understand the importance in patient access through education and understanding the why and how it impacts the rest of revenue cycle is truly important. And having those tools to be able to perform those tasks effectively. Reducing financial risk by addressing liabilities before the patient becomes resource intense to collect. So really important to have the ability to collect through scheduling, registration, point of service, while that patient is in front of you. And deferring low touch patients through automatic and digital channels. We're in a day and age now where you have connected patients and they want technology. They'd rather deal with the technology than with an actual person. So the key here is to targeting that population and that only prefers to use technology to help handle their bills. This would be your segmented low risk, low risk patients that can use virtualization, saves energy and resources so that you could focus on high risk patients. And then utilizing high cost resources. Typically we see that decentralized models where patients go to multiple departments to schedule their appointments and liabilities and estimates, as they go along. Being able to have algorithms, it gives a sense for more of those complex visits. It helps with saving costs by identifying the number of calls that go to a patient based on their situation, and it can help improve productivity. So we're going to talk about the different quadrants here. So when we're looking at segmenting patients into quadrants, you have your high, low touch. That's considered your patient engagement as a consumer. And then you have your high, low risk. That's the risk to achieve payment for the client. So the high touch, low risk are typically those insured patients. They have high financial risk if the patient is not guided and worked with constantly. They're low risk financially, meaning they have a complex, more comprehensive benefit plan. The benefit plan is in place, so they're low risk from an organization perspective because majority of the dollars are still coming from a third-party payer. But these patients oftentimes have complex care plans. So there's a complexity there in the amount of visits they may have. And there's a complexity around the services and types of providers that they have to see that require additional level of support to understand that revenue cycle process. So these could be patients that have complex or incomplete benefit plans, but it's really important for us to support that patient in understanding how their benefits are being applied and creating that education engagement with the patient, constantly keeping them educated and informed. Then you have your low touch, low risk here. And those are typically patients that don't want a lot of interaction. That's the connected patient. They want to pay their bill. They want it simple. They want it easy. And, this is one of the areas of populations that's currently underserved from an experience perspective within the healthcare system, but it's becoming more and more important and part of the patient population. So those patients have a simplified care plan. They have a comprehensive benefit plan. So even though there might be some risk on the patient liability side, it's very low compared to the dollars that you're collecting from the insurance company. These patients that are used to being connected from technology perspective, so they prefer electronic interaction, self-service interactions, and they want a simplified, easy to use process. With your high touch, high risk, this is your uninsured, underinsured population. So this is typically when you see in traditional eligibility enrollment engagements, you may have a financial counselor, you may have an actual in-house eligibility team, you may have an eligibility vendor, and being able to expand the review for any and all payers to cover the data service. So it's about creating a high touch experience, as it's both the patient and provider's best interest to guide that patient through the process to resolution. And then you have your low touch, high risk patients. So these are patients that typically don't have all the complexities, but from a financial perspective, they're most unlikely to pay, right? So this ends up being like your paper cuts over time. And this is where point of service collections comes in, and you want to spend a lot of, resource on trying to collect from every patient here. So the goal would be like, how do you identify the population that's underinsured and doesn't qualify for financial assistance, but has a history of non-payment? And how do you work with those patients to get them to engage? So in the high touch, low risk, we talked through what that looks like. Really the strategy there would be about having a solid, patient advocacy program, or we're going to talk a little bit later about patient balance management program. Having a team of advocates, that can help support that patient, helps them organize their bills, explaining their coverage. This is prior to them having their visits, or when they're ready to have a scheduled visit, or they need to have a scheduled, physician clinic visit, and being able to talk through what all of that means. What is it? What does the patient insurance education look like? And they're handling and explaining that insurance process during stressful situations. Contributors to success for advocacy or advocates for patients in this quadrant really is about helping with the bills and the insurance, and looking at everything from physician labs, pharmacies, hospital visits, being able to compile all of that and talking through it with the patient, utilizing patient portals and technology. And helps give that patient a little sense of independence when they have that support with someone to connect with. And the impact is, it does improve the experience. Patients do appreciate the comprehensive service, and it improves those relationships overall. When we look at the high touch, high risk, so this was your uninsured patients, your underinsured patients, maybe your emergency Medicaids, or people that are unfamiliar with, healthcare in general, or processes and policies. It's really important to have a solid delivery model with people, technology, and process. So people, you want to have people that I can identify who do you need on site and who can you utilize offsite. We're finding more with eligibility services that we can align a lot of the similarities with telehealth into what we call telescreening, and actually still get the same engagement. And being able to have the right technology, the right screening tools in place, and the right, workflow with your systems, and how you're able to identify the different metrics. Looking at your screening rates, your app rates, your conversion rates, and your aging stats, all very key when you're dealing with this quadrant that can help you with creating efficiencies in workflows. So just additional solutions here for that high risk, high touch, high risk quadrant. So community education, working with financial clearance, working with the financial assistance, being able to identify programs that are typically not traditional. There's a lot of new things that are happening in the market, qualified health plan enrollment. It's actually being offered to anyone that may have been unemployed in 2021. And that was just recently issued with Biden. And they're helping to cover the premiums for 6 months. if they enroll into a silver plan. So there's a lot of options that are becoming newer in this area. And then just making sure you have the right technology here again. So, propensity to pay, your presumptive charity, robotics and automation is key in this area. So you eliminate a lot of manual workflow. And then just ensuring you have that comprehensive workflow. All right, so we're going to go ahead and go to our next polling question. So which of the following, if any, do you perceive as the top challenge to leveraging virtual technology for patient engagement, i.e. telehealth or telescreening? So lack of technology access, lack of digital literacy in patient, low patient engagement, or other. Give that a few minutes. Or a few seconds, sorry. All right. So it looks like the highest percentage is the lack of digital literacy with the patient. And the next piece is the lack of technology access, and then low patient engagement. So I want to talk about telescreening a little bit. It's sort of a newer work stream. So essentially, things have evolved, especially with the pandemic. And, with the pandemic, we weren't allowed to see patients in a lot of those, emergency room care areas, and being able to assist them. So when you're leveraging telescreening and being able to try to work with a patient remotely, like when they're in the emergency room, or they're in, maybe they're at home and you're trying to connect with them, or they're at a clinic, you want to really think about defining what that scope looks like when you're setting up telescreening, right? So being able to think about it for eligibility enrollment services, or financial clearance centers, or patient balance management programs, excuse me, using it in emergency rooms or outpatient visits, clinic settings, in places where you typically do want to have that distance, and you want to be able to still connect with the patient. You want to define the scope and be able to review volumes and determine your coverage needs. With this type of telescreening, you can actually have the right caliber of staff that can support coverage during and outside normal business hours, which is similar to a call center. So, having 24/7 call center service for this type of engagement, because these colleagues are remote, and being able to have colleagues equipped with the tools to do their job. So engaging in video conferencing, having cameras like I have right now, having acceptable backgrounds, having badges, being able to have access to programs so they can do their job while they're engaging with the patient. From a technology setup, working with a program where you have like capabilities that have BAA compliance. So Zoom with BAA compliance standards, and having that with recording capabilities and waiting room capabilities, being able to have appointment scheduling for those more connected patients that want to schedule and talk to someone later. And then also being able to support patients that necessarily can't use their mobile device. So using a tablet or an iPad. And then of course, looking at securing of documents and disclaimers, looking at payment portals for securing those payments remotely, and electronic signatures. And then that Wi-Fi internet testing, right? You want to make sure you have workflows that are designed to establish queues for referrals, and they quickly identify patients to be connected for video conferencing versus using other modalities for contact. Maybe it's direct phone call, maybe it's an email, maybe it's a text message, or maybe it's an actual field visit. And then meeting compliance. So being able to ensure you have compliance in the process. So appropriate disclaimers, that are signed and acknowledged prior to connecting with that patient, making sure they honor digital communication with patients, And making sure patients have opt-out features. Maybe a patient no longer wants to connect video conferencing and you want to offer a different modality to connect with them. And then just having some solid reporting metrics, creating those mutually agreed upon goals for your service areas where you want to create this video conferencing from an administrative review. Examples could be maybe you want to reduce the number of self-pay recurring rates that are coming in over time in your ER. Identifying KPIs, for workflows to track and monitor. So like screening rates, app rates, throughput. Maybe you want to evaluate throughput and the time to screen or take the application. And then also looking at your collectible dollars for your service area. So I'm going to go next to the third quadrant here. So this is with the low touch and low risk. So this is the connected patient, patients like most of this audience today. They know healthcare, they want little interaction, they prefer electronic communication, and they want accurate estimates to what they owe. These patients are, they're usually with simplified care plans and comprehensive benefit plans. The connected patient is a consumer who demands to be at the center of the service. 72% of US consumers are more likely to choose a healthcare provider that offers self-service channel flexibility. 80% of US consumers have had a virtual care visit and will have another. So when you think about patients being the consumer and they want that self-service and the ability to shop for services and they want access to their data. Patients are more educated and they're shopping. So it's no longer, I'm going to call this 1-800 line. And somebody's going to get back to me and verify what I have. No, they actually want that real-time experience and receiving information on the spot. So ways that you can connect to a connected patient we talked about telehealth, but you have, the self-service portals, scheduling, registration, having alternative methods of payment by using credit card, Apple Pay, taking and uploading card information, getting access to online statements, online pay, and then just having the abilities to have records on demand are some of the ways that you can connect to a connected patient. So when we talk about the low touch, high risk, so this is your patients that are not engaged in the process, right? High bad debt typically, and they usually have high out-of-pocket cost. Point of service is really your best solution here for collecting upfront. Scripting is key, how you ask for payments, how you create best practices in point of service and overcoming objections, how you capitalize on that patient interaction, and reviewing past balances, identifying those past balances, setting up those payment plans, establishing automation, identifying opportunity for potential, eligibility enrollment if possible. And then maybe looking at utilizing the presumptive charity tool here as well. And then having that accuracy in cost estimations. You definitely want a high accuracy when you're talking with patients here. All right, so we're going to go to our last polling question. So what is your biggest hurdle when it comes to patient balance? Give that a few seconds. All of the above. I couldn't agree more. Improving collections, reducing uncompensated care, and reducing bad debt. Top 3. All right, so we're going to talk about patient balance management. So really, what's the value here, right? 40% of patients said their interactions with the hospital billing was influenced whether they would recommend the hospital to a friend. And 5 times patients with negative billing experience are more likely to complain about the experience to another patient. So in healthcare, we historically talked about the patient experience and journey, and it's mainly focused around the clinical process and clinical touch points, right? Experience, what the experience was with doctors, nurses, technicians, providing actual care. And today, the healthcare has a need of shift to a consumer-based model as a result of increased access to information and enhanced consumer experiences in other industries. So coupled with the rises in healthcare costs and consumers are now responsible for. In other industries, as consumers, you have easy access to compare features, benefit, costs, and review to guide your decisions. So in contrast, in the healthcare industry, we're presented with the array of confusing choices, contact points, service flows, without a lot of upfront information. And these barriers do include a lack of information around cost and options for managing those medical expenses. So to positively increase the consumer experience and meet the patients where they are, healthcare organizations must develop process, service, and experiences that align with consumer needs. The one way to do this is to become consumer-centric. Consumer centricity in healthcare does require that every team, service line, and department exists to serve the consumer in a streamlined way at every stage of the healthcare journey. So taking that approach, you call this patient balance management. The program streamlines and simplifies the consumer experience by integrating financial clearance, eligibility services, patient advocacy, all the way through back-end collection efforts for self-pay and bad debt, and it's supported by a virtual customer call center. So a consolidated team with visibility into full consumer journey. That is the data and process driven. It allows providers and patients to make better decisions by creating a partner relationship rather than a one-way dialogue. So ultimately creating the consumer-centric healthcare experience increases overall satisfaction and it yields higher financial return. So we talked about the confusing choices and contact points. So this is an example that will show, the patient here. This patient's dealing with various vendors regarding their bills, ranging from PFS to eligibility to FCC, bills that are with self-pay and bad debt, and all having different representatives they're working with. Example, the self-pay vendor leaves a message for the patient to pay on visit bill 4. But they don't know the patient has several other visits outstanding and they forget to leave a callback number. That happens, human error. Then the patient calls the PFS vendor who's managing bill 1 and they pay $400 on bill 1. Then the bad debt vendor calls the patient to make a payment and the patient calls back and says to the bad debt vendor, they already made a payment. And then the self-pay vendor is now sending a patient statement for bill 4. So there's so much confusion and frustration. Depending on your vendor partnerships, the patient can be dealing with multiple vendors regarding various bills that are in the revenue cycle process. The patient's left dealing with various points of contact, bill statements that they may have received, multiple incoming and outgoing calls, and many handoffs or swivel chair movement between various vendors or departments. So a patient shouldn't have to talk to 5 different people to get their questions answered about their responsibility. So what if a patient can talk to one person to get all of their questions answered and resolve their open account balances? Engaging in that strategic outreach ensures that the patient understands what and why they owe, and it will result in higher probability of payment. Customer service and consumer experience. So we think a consolidated team with visibility into the full patient balance will allow for greater collections and application of payments. And you can perform patient balance management at any toll gate at any service area, depending on the nuances within your facilities or areas. You could start the toll gate at early out. Collecting and identifying opportunities for eligibility and financial assistance prior to going to bad debt. You could start the toll gate at financial clearance, pre-service, and collecting not only for the visit, but being able to look at past balances and aiding and supporting that patient with options to help them get their bills covered. And you can support it at eligibility. So being able to look at various toll gates and depending on the nuances you may have. And the vision is to bring the process to the front, integrating with financial clearance and just being able to know how much a patient owes in totality when they're coming for their visit. And that concludes my presentation today. Is there any questions?